Hello, my name is Benjamin King. I'm a fourth-year medical student from Des Moines University, and today we'll be talking about Pimavanserin, brand name Nuplazid. I chose this medication purely out of curiosity. I learned about this medication about a month ago, and it's a very unique medication, so I thought I may talk about it briefly today. And if you've heard about it before, hopefully you can learn something new. If you haven't, hopefully you can um, share my excitement and joy with this medication as well. The clinical use of pimavanserin is in the drug class of atypical antipsychotics. However, it doesn't neatly fit into this box, and we'll get into those details. It was approved in 2016 by the FDA for a very niche clinical application. So it's used for patients that have Parkinson's disease psychosis, and it helps with the hallucinations and delusions associated with that. Improvements can be observed within the first 15 days or within the first month. And this study looked at 185 patients over 6 weeks and used the Assessment of Positive Symptoms scale, also called SAPS scale, to monitor for changes. It's a 9-item scale with each item ranging from 0 to 5. So a max score of 45 would be indicating worseness. So higher the score, the worse the symptoms. Pimavanserin was associated with a decrease of 5.79 in the SAPS PD score, compared to a decrease of 2.73 in the placebo group. The mechanism of action of pimavanserin is a selective serotonin 2A and 2C receptor inverse agonist-antagonist, and it has a much higher affinity for the 5-HT2A receptor at about 6 times that level of 5-HT2C. And the unique aspect of this medication is it has no activity at the dopamine receptors. It also doesn't interact with muscarinic, histaminergic, adrenergic, or calcium channels. So it has the ability to reduce psychosis without worsening the motor symptoms in Parkinson's disease. This is in contrast to second-generation antipsychotics, which do have some mild dopamine receptor antagonistic properties. And obviously this would worsen the motor symptoms associated with Parkinson's disease. So that's why this is such a novel drug, because it doesn't target the dopamine receptors at all. Dosed at 34 milligrams a day, the half-life is 57 hours. And in a study that looked at 199 patients in a 6-week randomized placebo-controlled study for patients that had been diagnosed with Parkinson's disease for more than 1 year, or older than 40, and had psychosis that started after the diagnosis, they saw some common side effects, including peripheral edema at 7% versus the 2% placebo group. Confusional state was 6% versus 3% in the placebo group. Some increased nausea and increased QT prolongation, as we often see with second-generation antipsychotics or antipsychotic medications in general. It has the black box warning for increased mortality of dementia-related psychosis, which was a 1.6 to 1.7 increase compared to placebo. However, the deaths were most often related to cardiac or infectious causes and not the medication itself. However, that increase is thrown on there, obviously, for that risk. The metabolism and implications. So it's metabolized by CYP450-3A4. So you have to be wary of inhibitors and inducers. So some inhibitors would be ketoconazole, clarithromycin. You may have to decrease the dose by half. For CYP3A4 inducers, such as St. John's wort, rifampin, carbamazepine, you may require an increased dose. And again, these drug interactions you want to be wary of. So you worry about class 1A antiarrhythmic medications such as quinidine or procainamide, or class 3 antiarrhythmics including amiodarone or sotalol, as well as antibiotics, the fluoxetine drug class, so moxifloxacin, and then other antipsychotics that also carry that QT prolongation risk. The advantages of pimavanserin, as we previously mentioned, it reduces hallucinations and delusions without worsening those motor symptoms associated with Parkinson's disease. There's no metabolic effects like second-generation antipsychotics. You do not need to change the dose of your dopaminergic drugs that are being used for Parkinson's disease, which is a huge benefit. There has been shown benefit of increase in your slow wave sleep, or N2, N3 sleep, which can be beneficial for patients, especially in the elderly population and those with Parkinson's disease. The disadvantage is that it's very expensive. It's about $200 per pill, which translates to about $6,000 per month. This is severely limiting um, which patients have access and financial resources to access this drug. Again, the risk of QT prolongation is a limiting factor, especially when considering other drugs that maybe the patient may be taking. And then it's very limited in its use. Right now, it is only FDA approved for Parkinson's disease psychosis. So current and future studies are currently looking at its use in Alzheimer's disease and Lewy body dementia psychosis. There are trials looking at its adjunctive therapy with schizophrenia, so in addition to a second generation antipsychotic. However, again, we mentioned that QT prolongation we need to be worried about. They're also looking at studies for major depressive disorder and its potential role in other neuropsychiatric conditions such as anxiety, amongst many others. These are my resources. If you have any questions, please reach out to me. I'd be happy to answer them. I hope you found this interesting and learned something throughout this presentation. Thank you.